move that we approve the minutes of Thursday, March 1st, 2012.
Okay, we have a motion, we have a second?
Second.
Any discussion or questions? Any changes? All those in favor say aye.
Aye.
Opposed? Okay. So today we got a pretty meaty agenda. We have two big agenda items. The first is, they're actually in, we're going to do them in the reverse order of what the agenda says because Richard Slusky is at a meeting and will be arriving a little bit late. So the first agenda item will be the briefing on the hospital budget process and some recommendations to us from Con Hogan, who's been involved in that process for the last several months. And the second item will be a discussion of, this says payment reform pilot evaluation measures. It's actually about how the blueprint and payment reform fit together. So, and I'll discuss I'll explain what I mean by that when we get to that presentation. So first, Con, please.
Okay. When we whacked up general responsibilities when the board was formed.
Whacked up?
Whacked up. It's a clinical term.
Carefully assigned.
I drew the straw that was the hospital budget process, and I'm glad I did because it's something that I had some experience with going way back, and I've always found very interesting. This is a proposal to the board for the FY13 hospital system budgets. First, it was a pretty thorough, participatory, collaborative process. Involved the hospital CEOs and their CFOs in a couple general major meetings over the course of time since October. And obviously involved VAWS President Bea Grouse and her key staff. Steve Kimball, Commissioner Bishka played a part at every point in the process. Anya leading the board, me as the assigned member to this one. Mike Davis, who's done this for
Since time began.
how many years?
He said too
25. 25 years. Richard Slusky, an ex-hospital CEO and now Director of Payment Reform for the board. And Bob Murray, who was a consultant from Maryland to the board, who's doing a variety of things for us, but he also helped us think through a couple key things on this. The process.
Maybe we should just clarify the board versus Bishka role.
Yeah, our board, the board role, we don't have authority yet on this. Our job is to make a recommendation to the Bishka Commissioner, Steve Kimball, and Steve makes the final call. But he gave us the informal authority to head the process because we're going to be into this after July 1 anyway. So that's why we have this. That's why we approach it in this way. We started in October with 3 group meetings with the CEOs, the CFOs, VAWS, Bishka, and the board. All during that period, the board visited virtually every hospital and sometimes made multiple visits. There was the formal side of it, if you will, began on 1st of January when we sent a letter to VAWS outlining where we thought we were. And then there came a period of considerable back and forth and clarification and testing and trying to find the common ground in correspondence and a variety of communication, resulting in this current proposal to the board, which again is only a recommendation to the Bishka Commissioner. Our charge, in a general sense, is pretty clear in Act 48, and that authority, as I indicated, doesn't really take effect till July 1, but the overall principle of controlling healthcare costs, that's a big, big piece of our work. The current proposal to the board. First, the broad aims of the overall proposal: to continue the trend, and I use the word trend, of reducing the rate of increases over a 6-year period. And in a moment, you'll see that through a variety of processes, that trend has been really quite pronounced and positive. Begin to connect hospital budgets to indicators of economic growth. Recognize that there are certain cost factors that are beyond the control of the hospitals, that we need to have open doors for them to come through to make further proposals if needed, and provide incentives for investments in payment and delivery system reform. The specific provisions, and again, this originally was based on the letter of 130, January 30 to VOZ. We connected the rate of growth to a financial indicator, the CMS market basket, which is projected to be 2.76 in 2013. But we also, over a period of discussions, adjusted that base upwards to a maximum of 3.75 for each hospital and the system as a whole, to help cover costs beyond their control. And some of them are pretty obvious. There is definitely age and income growth. There's investments in a new coding system that's required by the feds that the hospitals are going to have to deal with. The blueprint, IT investments, or most importantly, other necessary investments in healthcare reform. But the hardest part for the hospitals on this round will be that they are expected to manage utilization changes within this maximum. This does represent an early estimate of about a $78 million increase to the hospital budgets. The next two are just two graphic representations of where we've been and where we're going. That actual 07 represented a $129 million increase. The proposed budget for 13 is a $77 million increase. So really over a 7-year period, there's been continued moderation of those increases. The next chart, though, really, I think, shows the story even better. This is the percent increase experienced by the hospitals. You look back into 07, and it was a 9%, and that's when we were really roaring along. And then there has been a steady, solid, careful trend downward to the point where we're proposing today of the 3.75. Now, what are the things that really are, to some degree or another, beyond the control of the hospitals that we all felt needed consideration? The net patient revenue changes, any net revenue changes caused by an increase or decrease in net impact of the provider tax changes. That was a hot issue last year, but our early estimates, we don't think that's going to be a major factor, but that door should be open in case it turns to be a factor. This is an important one, this next one. The acquisition, there has been a solid trend of hospitals acquiring physician practices for a lot of good reasons. But we're suggesting that can only occur if it's a budget neutral or a system neutral cost. However, we do want to leave the door open for special circumstances, such as there may be a district where there is a physician shortage, a primary care physician shortage that we really need to address, because that's also a charge of the board to try to strengthen the overall primary care of the state of Vermont. Also in the news has been the state hospital and the role that the hospitals are playing in the overall plan that's beginning to emerge from the legislature. Those costs would be over and above anything that we've envisioned in the 3.75. So there definitely needs to be provision for those. And an increase in operating costs due to CON approvals that occurred during 2012. The hospitals should not be held accountable for those. Maybe a different story as we move forward and adopt whatever CON rules we're going to adopt, but not for this cycle. And obviously, we want our hospitals to be competitive in the northern New England states, so they're certainly held harmless for any increases in net revenue from an increase in people from out of state seeking care in Vermont hospitals. All this is based on what we consider to be a really solid performance for the current 2012 year by the hospitals. Mike Davis gets a 3-month review of very key indicators, and the last ones that are comprehensive we have through December. He's received most of the ones for January, hasn't received them all yet, but these trends look like they're still in place, and they are that expenses and revenues are on target as a system against the FY12 budget, that the operating surplus is according to plan, that the cost per adjusted admission is also on target, and the utilization for admissions, ER visits, and operating room procedures are actually under budget at this point. So we feel that the proposal we're putting in front of the board today is based on a sound performance by the hospitals themselves. Some other provisions. Budgets can be refiled in the face of significant state or federal policy change. We don't know what they could be. We can speculate about what they may be, but in some environment where something big is going on and something big is changing, we would hope and expect that they would refile budgets. We also want to encourage additional investments to support payment reform. If those investments are going to result in a return on investment in the form of savings over some reasonable period of time. And finally, to revisit the physician issue, just to make sure it's clear, the opportunity to make the case for acquisition of physician practices that are budget neutral, that do not cause a net increase in total spending or address a total physician, a local physician shortage. Now, the hospitals are concerned about some aspects of this, because anytime you tighten budgets, there would be concern. You would expect it. But as far as we could tell, these are the primary concerns that they have, that they are now responsible for managing the increases in the volume of services within the overall cap, subject, of course, to some major change in utilization. Additions to surplus and capital costs would also be included in the limit, and the proposal may not accommodate, they're worried that the proposal may not accommodate primary care physician shortages, but I will also say that that's one that we're going to watch very carefully too. Future thinking. These are not decisions. These are just things that we're beginning to think about as a board, and in each of these we would have some kind of a process with the hospitals to begin to flesh these things out. But we're beginning to think about a 2-year budget. Some of that suggestion actually came from a couple of the hospitals themselves. Part of our overall job is streamlining this complex system, and we can envision that 2-year budgets might be able to do that. But there's a lot of water that has to flow into the dam to even begin to approach it. Continue to tie growth to economic realities, which we're on that track. Start to think about developing a system-wide capital plan rather than one capital plan, an individual capital plan from each hospital, so that there's tighter possible coordination and less duplication of service or facility. And related, more streamlined and consolidated CON process. We haven't begun to dope these things out yet, but as we look ahead, we think these are the things that the next year can begin to bring to us. The onset, maturation, refinement, and scaling of payment reform pilots, and we'll be hearing a report on that a little later. And then the continued introduction of new payment reform methodologies. Okay, what happens next? After I complete this last page, we ought to have some good solid discussion, and then at some point a motion to the board to adopt the recommendation. And then we would communicate that recommendation to Steve Kimball, the BSCA commissioner. And then at the same time, Mike Davis would begin the process of budget instructions and data templates to the hospital so that they can actually complete the submissions, and that we're envisioning that in late March and early April. Final submissions due the 2nd of July. Public hearings, and that we need to work with the hospital association to figure out what the best focus and what the where and how to conduct public hearings and to what extent and depth. And final rulings on the budget by mid-September, and the budgets take effect on October 1. And just like a general continuation of working with each hospital and VAS on simplifying this overall process. So that's the recommendation to the board, and Madam Chair, however you want to proceed.
Thank you. I think at this point, I would take questions from any board members, and then I want to make sure we give you an opportunity to say anything you might want to say. Yep. And actually, first, let's go to Mike Davis. Anything you want to add?
No, I think this time we're fine. Some of those dates up there are by statute, and we'll have to live with them this year. You may want to change that in the future, but right now that's that.
Okay. Any questions or comments from board members? Yes.
I'd just like to comment that it seems it's a very important step, and it's one that we might comment on the process as well as the outcome. Seems very salutary in the sense of collaboration. From the beginning, we had some joint learning collaboratives that fed into the decision-making process. It's been iterative and based on data and trends. So I think it's really from a fellow board member's point of view who hasn't been the point person. It's been ideal as a model for how we might approach other topics that are also difficult and require the kind of collaboration that this one has. So it seems really terrific as an outcome as well as a process.
Al?
I think Alan should go first. So I know that we have a provision in here for investments that a hospital might want to make to support payment reform models. That's good. Has there been discussion about if a hospital does have a surplus under this fairly reasonable budget cap, the hospital can decide to use that surplus to continue doing the things that they have done in terms of adding providers or procedures that enhance revenue, or they can use that surplus. How are we thinking about incenting a hospital to use a surplus to continue to work on payment reform?
I think there are a couple of dimensions to this. First of all, the surplus issue becomes less and less as an issue as you continue to tighten down the overall spending. So I think that absent something fundamental that we don't understand, that the idea of huge surpluses or big surpluses in hospitals are probably not likely. Secondly, we're looking at this on a longer trend line basis, and if a hospital can become more efficient, for example, we're actually suggesting that it become part of their capital surplus, or part of their capital plan, or whatever. So we want to give them the flexibility in an ever-tightening fiscal environment to think about those things. So I hope that is responsive.
You know, I think it is. It's just that, you know, as the economy comes back, utilization is going to go up. So we have a window here where there might be, we've given a 3.75, there might be some opportunity for surplus that can be used to prepare for higher utilization rates, and
why
which we
CEOs
know are
do that.
coming.
That's what good management's all about. And I would agree. Yeah.
Al, do you want to say?
I have so many thoughts running through my brain right now. I'm trying to think about them on all the different levels. I think the first thing is I would echo what Karen said, and that I think it's great that, and I think it's important that things we do are collaborative. So I think that's great. Budgeting to me is, having done it in a small business for so many years of my life, it's such an inexact science, and it's such a struggle that that it's. I just commend the amount of people that got together to work on this. I mean, it's a tough thing to do, so I want to acknowledge that. But I will say that I would hope the goal is a surplus. I mean, I don't think. I think if at any point in time it was, if they were all to turn to a deficit, and that's probably not the proper nonprofit term, but I call it losing money. What's that? Panic. Yeah, I mean, so, you know, Alan, I think your comments are philosophically strong, but the problem is there's no numbers in them. You know, like what is a big surplus and what is a small surplus? You know, one person's, ceiling is another man's floor. So I think if we're going to talk about surpluses, that's when my idea of this whole thing is how do we come up with a plan that's multi-year? Because surpluses turn into next year's plan. You know, they don't have a special safe that they keep them in. You know, they roll into your planning. It happens at the town of Shelburne that I'm on the select board. The surplus becomes the thing that buys down the tax rate the next year. You know, it doesn't go to somebody. And I think we have to work on that. I'm really interested to hear what the people in this room have to say about it. And also a 2-year budget or a 5-year plan, or how we, because I know, talking with Con about this, you know, the more we can look down the river, probably the healthier for everybody. I hope I'm not taking that wrong. The questions I have are, and maybe you can answer these when everyone talks. You said what you thought was the hardest part for the hospitals. I'd love to hear what was the hardest part that you thought was the hardest part for the hospitals. I'd love to hear thoughts on special circumstances and if we've got them all, and if there's trust there, because most of my life is unknowable. No one knew Irene was going to happen. Next would be the state hospital plan and how we would deal with that. I mean, I know Fletcher Allen's doing some things now, or committed to some things, and how would that affect this, and is that knowable as we move forward? Then in the certificate of need process, that will tie into budgets, but it would really tie better into a long-term plan. You know, I mean, balance sheet management is more important to me than certificate of need process necessarily. I think there's an argument there to be made. And then the last point that I took from UConn is the competitiveness in the region, and how I know that Fletcher Allen relies heavily upon the North Country. I'm not as aware of the southern part of the state and the way the ebb and flows go there, but I think that, how are we going to address that over a 5-year period and be good at that? So those are I don't have specific questions. I kind of just have areas of concern. But go back to what I said in the beginning. I applaud everybody who collaborated on this. So I in no way am a critic.
Mike.
I think we can respond to a lot of that. Con, unless you want to first.
No, go.
If I remember well. One of the things this proposal does is sort of maintain some of the continuity we had in the budget process prior, which includes a review of the hospital's financial health.
Yeah.
So part of the budget decision each year is to look at the hospital's surplus, if you will. Not just the surplus, but their whole balance sheet, and make sure that they're in reasonable shape. And so we're maintaining that, not changing that. That's not to say that some hospitals might not need or want a greater surplus than another hospital. It's just the way where they are in their capital plan or where they are in their special circumstances. So we haven't changed any of that. And through this year's process, you'll see that assessment from us. And then you can make judgment as to whether that's sufficient enough, whether you want to change that, whether it should be different, and we can have that conversation. So in terms of what the right surplus is or how the surplus is handled, we haven't in the past directed hospitals to do anything particular with the surplus per se. We have questioned it, both being too low and in some cases being too high, we thought, in a given budget year. So just so you'll have that sense. In terms of CON, how would it work with the budgets? It would be, there is this connection to the budget process. It probably needs to be looked at. That is an area that's been talked about, is a better way to work with that. But once again, we did not change how we were operating before in terms of trying to get through this year's process. But there is a connection. As the hospital buys capital, those costs fall down into the operating budget and affect the size of the operating budget and so forth. Regarding the why would we care about bringing folks back from going out of the state in-state, the whole idea, it's more not about recruiting New Hampshire folks to come to Vermont or New York folks to come to Vermont. It's more about maintaining Vermonters in Vermont and trying to hold on to that market share or improve that market share. Because when Vermonters go outside the state, our information that we look at now, it's more expensive. So if we can hold them in the state, it's less expensive. That might mean bigger hospital budgets, but it might mean a lower overall cost. So that's what that migration piece was trying to deal with.
That's a great point, Mike.
And then maybe fishing. Okay.
What else is on your list?
State hospitals.
State hospital, yes. What will we do? We don't even know what that's going to look like yet. There's some different proposals out there. We've got an idea, and we've heard some different ideas. What we would essentially do is have the hospital resubmit that
Portion.
so we can see that, see what it does
Great.
to the budget, and then you'd be able to ask questions at that time when that happens.
Okay.
That's at least that conceptually. There may be some other formal aspects which I'm unaware of that we may have to do, but at this point, that's how we handle it in the budget process. So if something breaks in July and they've already submitted their budget, they'll have to resubmit. We'll have to set up a process with them for that.
Okay.
One thing the budget process, more specific rules have also, is a provision for the hospital to come back when they might have made a mistake or might have seen things change so drastically that they feel like they need to resubmit. We have that in the process, and that will remain in the process. And part of it is really you'll be moving the decision-making from BISCA to this board, and you're not yet armed with what's happened and what are the tools you have. But by the time we get there, hopefully you'll be better armed, if you will, to make decisions around those budgets.
Yeah, I'm getting back. We're going to hear about payment reform in a minute, but I think, Al, you mentioned my philosophical approach, but payment reform is not, the premise of payment reform is improving quality. Okay, we have 14 hospitals. We are giving the hospital budget now, if there's 600,000 Vermonters, is adding $130 for every single Vermonter within that hospital service area, or that's just the way that we're increasing by $78 million. We have 600,000 Vermonters, so we're adding $120 to $130 for every Vermonter. And so, I think it's so important for the hospitals to start thinking about how are they using that money to really change their business, some of them, and what's important and what they're responsible for in terms of quality, in terms of improving the design of the system to improve quality. So that's my philosophical point. I've done budgets for departments, but I haven't had your experience in business, but I keep it simple. $78 million, 600,000 Vermonters, that's $130 for every Vermonter next year. And at what point are we going to have the kind of system that really looks at using that money to improve the health of those Vermonters?
And Alan, I have to respond just a touch. I don't have the number right in front of me, but I'm guessing that that's down from
Oh, it's
$230 a Vermonter change. So, I mean, this really is a process, it's a trend, but your challenge is right. I mean, how do we do business in a fundamental way differently? This budget does not address that, other than open up the door and the opportunities for some payment reform possibilities.
And some delivery system design changes that really focus on quality.
So on that note, I think that's a great summary, Con, and I want to thank you for your hard work on this. You did a great job pulling this together and shepherding the process. I do think this represents progress in terms of the hospital trend, and I think we can continue that into the future. A couple of things I wanted to say. One relates to what you just raised, Alan. I think that this is only our first, sticking of our toe into this, into our new authorities, and there are a lot of pieces to be connected still. This is a positive trend in terms of continuing the downward pressure on hospital budgets. That's only 40% roughly of our healthcare expenditures in the state. So there's a lot that is not affected by this. And we need to look at both how do we affect the rest of that, and that $100 and whatever that this represents for every Vermonter, how does that get distributed in terms of payments from public programs, payments from commercial insurers. So we need to really connect this with the insurance rate process over time, with reducing cost shift over time, and as you noted, payment reform and delivery system reform, and figure out how to make all that much more explicitly and tightly connected. On the issue of trends and indicators and sort of surpluses and looking at this over a longer period of time, we did look at other indicators of financial growth and economic capacity during this process. We looked at things like gross state product and CPI, some of which are quite a bit lower than the CMS market basket, frankly, because our income, as most of us know, isn't growing a whole lot right now.
We looked at wage growth.
We looked at a variety of indicators. In the end, this seemed like, for this period of time, a reasonable thing to light on. I think it will be an ongoing issue for us to both think about what's the right indicator or set of indicators against which we want to match our healthcare expenditures, and to what extent do you want to buffer the ups and downs so that this is so that we're recognizing our capacity to pay an economic reality, but we're not riding economic cycles in our healthcare delivery system. And I think that's part of the advantage of a highly regulated system, is we can smooth out some of those cycles. The disadvantage is you have to sort of arbitrarily pick what's the right rate of growth. So I think that's going to be a big issue for us as we go ahead in time, and it will be easier to look at that and make decisions about that if we can get a broader window. But that's easier said than done. And then lastly, I'd just like to say, because we are making a recommendation to the board and hopefully voting on this policy today, I want to make it explicitly clear that there will be an opportunity for public input in this process. So while these will be general guidelines for the hospital budget process, there will be an opportunity for the public to comment both on the general effect of our decisions and on specific hospital budgets at some point later this year. And I didn't have any other comments. Anybody else up here? If not, I'll ask B to comment. Okay, B, you want to say something?
Just so I don't have to talk about it.
Yeah.
Sure. I don't have a whole lot to say. I wanted to start out with the thanks. I think it was a very good process, and appreciate Con and Anya sitting through all those meetings and going through all the back and forth, but I don't have any recommendations for any change. I think that hospitals certainly deserve the credit for bending the cost curve. You know, we've been under revenue targets for a couple of years now and take this process very seriously. This is a step in a longer continuum as we try to figure things out. And I think that, Dr. Ramsey, to your comment, I think hospitals are working hard to take care of the population we serve today. And I think one of the challenges is that that need is not static. It is ever changing and getting more complicated as we all get older. So I think looking forward, we appreciate that and recognize that, you know, we are in very challenging times. And I think that figuring out how to generate a surplus in these challenging times, we hope would be considered to be a good thing. Would be a sign of success, actually, if hospitals can figure out how to generate a surplus, given this framework and given the challenges of healthcare reform. I think would be a sign that we're figuring out. We're seeing a little bit of clarity through the fog of all the different things that are happening ahead of us. So,
and you know, it's not like New Hampshire, where they're suing the pants off each other, right? I mean, it's so important. Look, there are going to be times we're not going to agree on stuff, but the fact of the matter is, as long as we keep talking and try to work together, better things will happen.
yeah. No, I mean, no,
Yeah.
but good point, Con.
Yeah.
I mean, if it was easy, we would have done it already.
Right.
So, I mean, there are so many complicated issues, and certainly the provider tax and payment issues that New Hampshire are going through, we are also going through those, and they are extremely challenging and will continue to be extremely challenging. We certainly have chosen to try to work collaboratively on finding solutions to them. You know, I certainly hope we do. Like the state hospital, we have chosen to try to step up to the plate and try to find solutions for that very challenging issue and figure out how we can manage the care today while we're planning for better care for tomorrow. And, you know, it's a step-by-step process.
Thank you.
Sure.
Anybody else have any comments at this point? No? Okay. So, Con, I think at this point you'd be looking for a motion.
Yes, I would entertain a motion that the proposal is presented be accepted and referred to Commissioner Bishka, Steve Kimball.
So moved.
Second.
Any further discussion? All those in favor, say aye.
Aye.
Any opposed? Okay, thank you very
Thank you.
much. Thank you. All right, so now we're going to go into agenda item 2. And you know what, Thomas? I told you I was going to do it from here, but Richard's going to be doing it with me, so that doesn't make any sense.
I can let him sit here.
Is that easier if we put Richard here?
Would you take your sign with you if you go over there?
You have to take your sign with you.
Richard, come here now. I can sit over there or sit where you're sitting.
Or you can sit next to Mike.
Yeah.
Which reminds me, I'm going to take this little interlude to introduce to you all Mike D'Onofrio, who's our new general counsel. Joined us yesterday, came back to work today, so we're very happy. Mike comes to us from the Attorney General's office, where he has accomplished a lot, and we're very glad to have him with us. And welcome, Mike.
I'm glad to be here. Looking forward to learning a lot. Thanks.
Thank you. And so, Richard and I are going to be talking from this set of overheads, which you probably should have.
Thank you.
I was trying to remember exactly where this subject matter came from. At some point, in some meeting,
You said.
somebody said, I don't understand how the blueprint and payment reform pilots all fit together. And I said, well, I do. So we decided to schedule a meeting, because Richard also does, at which Richard and I explained to you guys what our concept at this point in time is of how payment reform and the blueprint fit together, and we're going to talk about it in two respects. The first is sort of generally in terms of delivery system and payment reform. How do they dovetail, at least in our minds? And the second is in terms of our early thinking about performance measures and evaluation. Where are we starting from with the blueprint, and how could that feed into what we do in terms of performance measures and evaluation for broader payment reform? So Richard and I are just going to, I don't know how we're going to do this because we haven't really.
Yeah, I want to do the first part, and I can do
Okay.
some of the fun.
So the purpose of this presentation is to frame a discussion of how these things fit together, to describe the performance measurement that's already underway, and to discuss the potential performance measurement in the payment reform pilots. And just want to make clear at the outset that this is not recommendations about performance measures and pilots, but just some really general thinking about how they could fit together. And actually, before I go any further, I'm going to hand this out because it goes along with the presentation. There. And the extras can go out to, yeah. So, part one, how do they fit together? So, Act 48 actually requires connections between our work and the blueprint. So it's no mistake that we're talking about this. And it requires connections in two respects. On quality oversight, which we have been operationalizing so far, mostly in terms of our discussion about a dashboard for quality measurement. There is a specific requirement that we develop our system-wide quality measurement for numerous dimensions, which I've represented by ... in consultation with both the Department of Health and the Director of the Blueprint for Health. So an explicit recognition that there's stuff going on in state government already related to quality measurement, and that what we do should not be disconnected from that. And then secondly, the law requires that the payment reform pilot projects follow further the objectives of aligning with the Blueprint for Health strategic plan, and that healthcare professionals in those pilots should coordinate care through a local entity or organization, which results in a sustained focus on disease prevention and promotion of wellness, which is what the Blueprint is all about. So while the Blueprint is not mentioned by name in that last bullet, I think we can assume that there's a strong connection in that. So originally we had scheduled Craig to be here to talk with us today. Poor Craig got called to Hawaii on an all-expense paid trip to give a speech. So we're going to say all sorts of things that aren't true about the Blueprint in his absence. No, we're going to do our best to describe what the major elements of the Blueprint are. Craig will be here himself in a couple weeks to talk about the latest Blueprint annual report. So at that point he can correct anything that we said that's not true and go into a lot more depth about the progress of the Blueprint, its scope around the state, and the results of the evaluation of it so far. He did review these slides, so he did have a chance to say if I had anything totally wrong. As I see it, there's three major elements to the Blueprint. The first is the clinical model, the second is the financial model, and the third is the model for performance measurement and evaluation. These are all connected, obviously, but they're the three big parts that I think of in describing the overall Blueprint. And I just want to make clear, I know we had a little bit of discussion about this recently as well, that the Blueprint model applies to all patients served by a primary care practice that is a Blueprint practice, that is trying to achieve the level of a Blueprint practice. So it's not just aimed at patients with specific conditions or patients who meet specific criteria. It's all of these interventions and reforms are aimed at all patients served by the practice. The clinical model involves a team-based advanced primary care practice, meeting standards that are set out by the state, mostly guided by NCQA guidelines for what an advanced primary care medical home is, and then augmented in Vermont by community care teams, which are groups of folks who serve multiple practices and essentially extend the capability of those practices, particularly in terms of connecting patients with social services and things that would normally be outside of the primary care practice but are important to maintaining the health of the population. The financial model is that there are targeted payments on top of fee-for-service for reaching certain thresholds, either of capacity, so a practice is able to do something, or proving a certain level of clinical performance, again guided by NCQA standards. And the practices receive a PM per member per month payment, per patient per month payment, but the underlying payments to the practice for services provided are made on a fee-for-service basis. And the range of the PMPM is what now?
$1.29, I think, to $2.49.
So depending on the level of the level that the practice has achieved in terms of these thresholds, they can get anywhere in that range in terms of PMPM payment. The third part of the model is collection and feedback of a wide array of quality and cost measures, and we'll talk more about that in a few minutes. The targeted payment streams, this is Craig speak, so I'll just, Craig did this slide, you can tell if you. So the idea here is, and we've heard Craig talk about this, that the payment streams are really, the idea is to target the money to pay people to do the right thing. In this case, transform their practice operations to meet these NCQA standards in terms of health information technology, quality improvement activities, and so forth. To implement team-based care, so to really redesign how practitioners are working together, to implement the quality improvement, to work with the community health teams and the community health team extenders, and to routinize panel management, so to start to think about their patients as a population for which they're trying to track clinical problems and progress in addressing those clinical problems and in preventing problems. So that's the blueprint. Now I'm going to go to payment reform pilots, and then hopefully I can make a case that they fit together. So the major elements of the payment reform pilots are a move away from fee-for-service. So unlike the blueprint, which is based on this fee-for-service payment with an add-on, the purpose of the payment reform pilots is to move away from fee-for-service to units of payment that reward a lot of the same things that we're rewarding through the blueprint, but do it through some larger bundle of payment, either for an episode of care, for a range of services, or for all services to a patient population. And we've talked a lot about that. Anything you want to add on that one?
No, we'll get into more specifics.
Okay. And the idea of making this movement away from fee-for-service is to reduce cost growth, emphasize better quality, allow providers to, within the new payment streams, to worry less about the volume of services and more about prevention, care coordination, and quality, and be rewarded for those things which now they don't receive explicit payment for, and to improve patient and provider experience, which again is part of the idea of the blueprint, but the payment reform pilots are trying to now more fundamentally change the payment model underlying them. And now Richard's going to talk about.
So specifically, what we're looking at are 4 different payment models for consideration. And each of them is in a different level of development right now. We have, I think you're mostly all aware that we've contracted with Bailett, and he's working with, so it's Michael Bailett, Mark Pedrazik, and Bob Murray, who are consultants working with us on 3 of these 4 models. And it's important to understand or recognize that the development of these payment models, as Anya said, are intended to reinforce delivery system change, to try to facilitate that change and produce better outcomes and improve quality of care and hopefully more efficient services. This is the consulting contract we have with Bailey and Pedrazik and Murray are under the auspices of a federal grant, planning grant that was awarded to the state for the development of the exchange. So this is all connected to the development of the insurance exchange and how payments might be made to providers through the exchange. So, or not. So this is broader than the exchange, but part of the exchange development. So let me just go into a little bit of detail on these different models. One is the bundled payments, and this, the Hospital Association and the state about 3 months ago now, I guess, submitted an application to act as a convener on behalf of the hospitals who might be interested in pursuing bundled payment opportunities. Bundled payments are specific payments around identified procedures or diagnoses, usually procedures, but it could be a diagnosis. So you might have a joint replacement, for example, and the hospital would receive a fixed payment for that service, which could include all hospital services. It could also include hospital and post-acute services. So those are the two models that we've identified.
3 consultants, so we probably don't have to go into
Yeah, I won't go into it.
Remember, they all sat there.
Oh, yeah, they did sit there. I tend to repeat things just because when I do go to a group, they usually don't remember what was said before. So I think it never hurts. But what we would like to take this a little further in Vermont and make this all payer bundle payment. So if we do a bundle payment model, we'd like Medicaid and the commercial payers involved as well. So that's the approach we're taking. The Blueprint specialist model for targeted conditions, I think we have talked about quite a bit, and this would be engaging the specialist with the PCPs to agree to better coordinate care for patients with specific chronic conditions. And so that's another model that we're pursuing. The physician hospital global budgets would be a payment to the hospital, and in Vermont, as you know, about 2/3 of the physicians are actually employed by hospitals. So it could be broad enough to include a good portion of the physician services provided as well. This is a model that Bob Murray is going to be facilitating. He's very familiar with this because of the Maryland experience. They have about 10 hospitals now in Maryland that are being paid under the physician hospital global budget. I think the specific characteristic of this that's notable is that it changes the mindset of clinicians and administration from revenue production to management of costs and looking to become more efficient. Once you're under a budget, you're really thinking more about the management of your costs within that budget. And then population-based payment would be for probably a larger organization or a hospital or organization that has a large market share within their service area and provides a broad base of service, range of services. So, and that would be a capitated model similar to what Fletcher Allen and Vermont Managed Care are operating under currently. All of these are aimed at supporting and developing clinical models that reward high quality primary care, which is the connection to the blueprint. So again, the foundation of all of these rests in the primary care models and making sure patients have access to care, and the integration of primary, secondary, and tertiary care. And then you can see graphically.
And it's a beautiful world.
That's right. It's a perfect world in full order.
And it's not a Venn diagram because Georgia didn't like Venn
I
diagram.
like the Venn diagram actually better because it just connected a little bit.
Can I just make a point or ask a question?
Sure.
When I got on the board, you didn't even work here.
That's true.
And now you've taken over everything.
Yeah.
What exactly is going on here, Mr. Slusky?
It's a control need that I have.
Thank God we have you.
Yeah, right.
Sincerely.
Do you want me to explain my picture? Because it kind of...
I think it's beautiful.
For those who are into
I think it's
graphics,
clear.
the idea here is that the blueprint really is foundational. So any of these models not only should include good primary care, which in Vermont we've defined as blueprint, but also we are explicitly required to include that in what we do in terms of quality measurement and payment reform, so it makes sense for there to be a strong connection. That doesn't mean that the blueprint as it is now is perfect. I think that one of the things that we'll have to look at, because we're using this as a foundation, is where are the gaps in it over time that are identified, and what do we need to do to fill those? A couple I can think of already are, there's been talk about whether the payment level is too low and whether we need to invest more in it to make sure that it's a successful model. Whether the connections with mental health are as strong as they need to be. So I think keeping our noses in blueprint evaluation is really important as we look at this as something we're really trying to make sure is the foundation for everything we do. But the success of any of these models, if we're doing it right, depends on primary care capacity, so having an adequate supply of primary care, adequate access to it, primary care quality, making sure it's good care, good primary care, and making sure that there's connections between primary care and other levels of care.
I just want to add, since Susan is here, and we just actually had a conversation this morning, that all of the FQHCs in the state are now blueprint practices. And I think the intent certainly of the FQHC model is to broaden the access for patients who at times can't access healthcare services easily, and also so low-income, uninsured individuals, and also delivering a broader range of service, including mental health services, dental services, et cetera. So it's important to recognize, and I need to be reminded of that from time to time, that the FQHCs now are serving about 25% of the population in Vermont. And that's a model that Senator Sanders has really supported, and there's been a lot of dollars invested in the FQHC system in Vermont. Pete?
Is it okay to ask a question?
Sure.
I had a couple of mechanical questions.
Mike, please.
Sure, I had a couple of mechanical questions. I think my first question, and you brought it up with the FQHC, that currently the blueprint is paid, blueprint physicians are paid fee-for-service with an add-on, and the payment reform models are all moving away from a fee-for-service. So for a hospital, for entities that employ physicians in a blueprint practice,
Is your mic on?
I don't know. That's on.
Okay, thank you.
So for blueprint practices that are within the hospital world, what would the transition be? Because you're going to have a hospital moving away from fee-for-service, and you are going to have you're going to have that revenue coming into the hospital on a fee-for-service basis. So
The physician revenue?
Yeah, I mean, if they're employed, they're employed, but
Right.
but they're still billing on a fee-for-service basis.
Yeah, I think we need to look at that, because if the physicians remain paid, I mean, they're employed physicians.
Right.
But, traditionally, the hospital employed physicians are, as a CEO, I was reminding physicians of their volume production and how many tests they were ordering and things like this. And that's what we have to get away from. So, because, that would be total misalignment if you've got the hospital on a budget and the physicians being incented to actually see more patients, do more things.
So how would you do it? That's what she's asking.
Well, I think what we would do, for those employed physicians, could be included under the budget of the hospital. And then you've got an aligned opportunities, and the incentives would be around quality and performance.
And then,
Now, they could still bill. There's still going to be transaction requirements that would still be in place, but there may not be payments made on the basis of fee-for-service.
Well, and just an observation, but you are creating two very different evolutionary streams, so to speak. If you are going to evolve physicians in the hospital world to kind of move away from a fee-for-service within the Blueprint model
Right.
as part of a larger payment reform in that hospital community, and then you had FQHCs still in a fee-for-service model, which generates, in that environment, more of a more of a volume-driven growth model. And again, I don't know whether that's good or bad in the grand scheme of things, but
Right.
but you're just creating two.
Well, I
separate
think what I mean, the thinking on this has, and I've talked with Craig about this, that the incentive payments that are going to the Blueprint practices, we would hope would start to transition away from fee-for-service and more toward performance. Now, the question with the FQHCs is how does that impact their funding streams, and would that be a negative impact on them? And I think that is not the intention. I mean, the intention is to maintain the dollars, but have them be paid in a different way.
But
So that's something that we have to look at.
And it's a good example of the kind of thing we'll have to model, and
Right.
hopefully we'll have a live example of where an FQHC and a hospital together, or as the same entity in the case of Springfield, where we have to peel that apart and say, okay, if you move to a new model, what are the implications for the federal funding?
Right.
How would you continue to figure out what the chunk of money is that now comes rather than the little bits?
And how does that affect admissions and readmissions and
Right.
therefore
Right.
overall
Right.
overall spending?
Right.
So that's the modeling that the consultants are going to be doing. And again, the intention is to provide more resources, not less, to primary care practices through the community health teams, through enhanced payments, et cetera. So that is the foundation that we're building.
I have a question similar, but from the other angle, not from the hospital and physician side of it, but from the community side. So right now, as the Blueprint grows, the community health teams, the Blueprint ones, in some cases are providing brand new services. In other cases, they're bumping up against other community services and teams that were there before. And then there are the sort of more independent entities like the Retreat or Sojourns, that's more on the healing side as opposed to the clinical service side, that in a sense aren't connected to the Blueprint or the payment reforms yet. So how would we, or Craig, encourage them to go, in a sense, to try to join through the Blueprint door or try to be part of a payment reform? Because at the moment they are quite separate from any of this.
The Retreat actually is involved in payment reform discussions, but I think the general point is a good one, and I don't know the answer.
We don't have a direct answer to that. I think a lot of that discussion is actually being considered in the Duals project, because you have a lot of community-based programs, care management programs, different types of services to individuals that aren't in the traditional healthcare world, and how they get incorporated into, the Duals program, I think is going to provide a lot of guidance as to how we might do this in an overall payment reform. But it is being addressed. What we don't want to do is create duplication of services where everybody's siloed and you have, everybody has a small piece of the patient's care, and there 5 people are calling for different services. So I think we have to be careful about
What
that.
I've been hearing a lot as I go out and meet with people is more the concern, not the duplication concern as much as that almost overnight their model will no longer be revenue producing, because in a sense the money is going to shift to the pilots or to the Blueprint.
Richard and I wish we were that.
That's what I was going to say. I don't think there's an overnight concern about any of this.
I'll give you a real world experience of being an employed physician in a hospital system, part of a patient-centered medical home, and being paid fee for service, so I got to generate RVUs, gross billings, visits, and getting a per member per month, getting our first per member per month additional income, and the practice deciding what are we going to do with that, and the practice decided it wasn't quite enough, but what we wanted most was to hire a panel manager so that each one of us would know in all the patients we take care of, how many are well, how many are have chronic illness, how many are at risk, how many are in recovery from a hospital stay or something, where we could really use the sophistication of that panel manager to target our resources, which are still limited because we don't have enough family doctors yet, to those people who we can treat most aggressively to keep the cost and improve the quality. So that's what we decided. And we didn't think about, how's this per member month going to increase each of our salaries? We're still within that fee for service. But just thinking that way started to get us to transition away from fee for service, RVUs, gross billings, towards improving the quality of a whole group of people. And that was a really exciting time when we got that first check.
Okay. All right, so now we're going to move into the section on blueprint and payment reform performance measures. How do they relate? Unless there are other questions on that. Bea, did we cut you off in terms of your questions?
I just had one other quick question on the expansion of specialists into the blueprint model. So I know that when we went to Washington, CMS was not all that psyched about that idea. Have you followed up with them, or are they kind of warming up?
Well, they'll be up here Friday,
okay.
the 16th.
Okay, so you're going to reapproach them on that because, again, I think it's a good idea, but.
Yeah.
Okay.
And chronic conditions, most of the patients were probably Medicare patients, so not all, but a good percent would be.
But cancer care is just one example where I think that.
And that's actually we're doing with. Tony Rogers is coming up from the Innovation Center, and we're actually going to have the steering committee from the oncology program present this specific program to him to show him what we're doing and how we'd like to factor that in.
Great.
But you're right, their general thrust is very much away from fee-for-service, and so they weren't overly excited about building on this targeted payment model.
Right, but maybe if they saw the grander plan, that might see that as a step in the process. Okay, thank you.
All right, so now moving on to performance measurement. First, why do we care? Why do we get so hung up about performance measurement as we're looking at any of these models, but particularly as we look at some of the payment reforms that move away from fee-for-service? Well, we all have talked ad nauseum about the fact that fee-for-service contributes to overuse of services that have little or no benefit, and that it doesn't pay for things like coordination of care, phone calls, other things that might be done to manage patient health at a lower cost with more effectiveness. And payment reform models introduce financial risk both to contain overall costs and to improve quality. So trying to shift the focus from providing more services to providing the right services and being able to create an incentive for cost containment because providers can share in the cost savings. The downside of this is that the financial risk might promote might motivate providers to reduce sorry, I'm on the second one. I can't even read my own writing. When you start tripping over your own sentences, you're in trouble. So the financial risk could do what we intend for it to do, which is motivate providers to reduce overuse and inappropriate care and to better coordinate care. That's what we hope for. That's why we're pursuing this strategy. But the downside is that the financial risk can also lead providers to either reduce services that are important to high-quality care or reduce access to services. And we certainly have seen this in some of the earlier examples of things like capitation. So performance measurement becomes imperative as a method for making sure that under these models you're getting good results and not bad results. And here is, you what used to be
Yeah.
my favorite chart, and now it's Richard's favorite chart.
Well, I think this sort of portrays well the different payment models that might fit different sized organizations or organizations that may be more or less ready to accept risk. And Anya made me read a book this weekend so, on chaos and organization of healthcare, which was actually very interesting. I mean, the one thing about it I found was that it validated much of what we were doing. I mean, so it seems that that the principles and the philosophy that we've been following here is very consistent with what people are writing about today, and seems to be where the world is going in healthcare. We've had several physicians who are, 1 or 2 person practices and coming up to me and saying, well, how am I going to put in an electronic health record? It's $40,000, and, I don't have the staff to manage all this, and, how are we going to accept per member per month payments for a panel that we're managing? And so they're very concerned. I mean, there aren't a lot of practices like that, but there are some, and I think the authors of this book really sort of painted the new world picture as saying that in order to really function well in this new world, you really are going to have to organize into some kind of larger practices or systems. Now you can remain a 1 or 2 person practice and become part of an IPA, an independent practice association that may accept risk on your behalf. But to remain an independent practice, unassociated, unaffiliated with anything, is realistically going to be very difficult. And I think, we probably should be honest about that. It's not that they provide poor medicine, it's just that the expectations that are going to be placed upon practices are going to be very difficult for them to meet. And so this really just describes the evolution of payment methodologies that as they might be appropriate to different size practices. And you can see, you have the P4P Lite, which is just sort of contributing information to a registry. P4P more robust, using a full EMR. The case rates or bundled payments would fall into a category where an organization would be more integrated and more ready to accept some risk, and then sub-capitation, where you would take per member per month payments for a defined set of services as opposed to a full range of service, and then full capitation for a very broad range of services with a good deal of risk. Now, in any of these systems or in any of these methodologies, you can define the risk corridors. So, I think if we went to a hospital today and said, well, we want to give you a global budget, or we want to pay you on a capitated basis, they would be reluctant to do that without knowing some limitation on their risk, their financial risk in that model. So it is certainly possible to define those risk and reward corridors.
And so I said performance measurement becomes imperative as we move through some of these reforms, through this evolution. And it's really for 2 different reasons. And I'd say to some extent they're on different parts of that spectrum on the y-axis. So on the next slide I say what the 2 are. One is for setting or adjusting payment amounts. So particularly if you're dealing with the P4P payment methodologies, but also to some extent higher up, you may want to set what kind of payments, what amount of payments you're funneling to providers, getting to Craig's idea of targeted payments. You want to set them or increase them based on performance relative to these indicators. And then the second is to protect against the adverse consequences of cost containment, and that's at that sub-capitation, full capitation level you start to get concerned about the adverse consequences. So at both ends of the spectrum it becomes really important to have good performance measurement. So the best study I've seen of performance measurement in payment reform was one that came out last year from RAND. It was in large part a compilation, and I've handed out some excerpted pages from it, a couple of tables that I thought were particularly good. It's a compilation of their sort of environmental scan of what are all the payment reform models that are out there in the United States. They looked at 90 different models. They collapsed those into 11 general categories of payment reform models, and they did this. They were hired to do this by the National Quality Forum, which is, you know, the big gurus on quality in the country. What they came up with was a list of the kinds of measures that are being used, and then some recommendations about where a lot more work needs to be done. You know, in the 90s we had capitation, and we worried about the quality of care when there was too much risk placed on providers, and at that point in time we had pretty limited means for measuring quality and assessing the extent to which we were having adverse impacts on quality. I'd say the good news is today we have both better data and better measures for measuring quality, but we're still pretty limited. So if you look at the kinds of things that are in use now, there's a great variety in terms of the number, type, and sophistication, and there's still a real lack of sophistication in certain areas that we will care about over time. So we should be supporting and hoping that there's a lot more effort on this. And as I said already, complex models require more complex measurement systems, so as we get into some of those capitation models, we're going to have to worry more about additional dimensions, additional measurement, and additional reporting. Some of the areas that RAND points to that are particularly troublesome in terms of needing further development and refinement as we expand these models include health status and functioning, safety, so things like errors, medication errors, infections, and a lot of that gets to the lack of sophistication or agreement around risk adjustment, so how to compare across providers and across institutions, measures of care coordination, measures of patient and caregiver engagement. There is some work that's been done on that, but it's really in its early stages and not widely used yet. Work on composite measures, so ways of taking a lot of different measures and rolling them up so that you can get an overall sense of whether you're getting good or bad quality out of the system. Likewise, combining quality and resource use into efficiency measures and measures of access to care. And we still rely largely on things like the NCQA measures, which Craig has built into the blueprint to a great extent. And we still rely largely on claims data as the source for doing this kind of measurement. And over time, hopefully we can be more sophisticated about it, but it requires investments. You can't read any of this up on the screen, but hopefully you have it on the paper in front of you. So this is, if we think about what does the blueprint offer us in terms of evaluation measures or performance measures that we could use for payment reform more generally, there are 5 categories that are currently captured in the blueprint evaluation. There's a gazillion measures within these categories. If you look at Craig's regular reporting, there's a whole lot of stuff, but I tried to just collapse it into some general categories that you could understand. So he's currently looking at utilization, and I give you some examples there because there's a whole lot of different types of utilization measures he's looking at, and I thought you'd want to know what some of those are.
This stuff is terrific.
Yeah.
I mean, this is really terrific to be able to start to hold the blueprint in a positive way to these kinds of standards that really connect to the other work we're doing.
Yeah. Yeah, so and then I think the question becomes, how do we have to go beyond, how should we go beyond this as we contemplate other models of payment reform? But I don't think that there's anything that's here that you would say, oh, that's stupid, that's bad, we don't want to build on it. So right now he's looking at process of care measures related to diabetes. These are the HEDIS standard diabetes measures. But not at other conditions. So one area for potential expansion is to other conditions. He's looking at total payments for several different categories of care, slices and dices it in a number of different ways. Looking at provider experience, which is a qualitative assessment with focus groups. I think B, is this the part that did you do some of this work, or was that the patient?
The qualitative assessments?
No. Or is this what UVM's doing?
UVM's doing
Okay.
it, yeah.
Okay, so
In the patient experience.
VCHIP is doing these last two, VCHIP at UVM, which stands for something. Vermont Children's Health.
Insurance Health
some-
Program, Health Insurance. Yeah.
They are implementing these last two, what do I want to call them, dimensions of measurement, provider experience and patient experience through focus groups, and I believe the patient experience is through a survey.
So this is Judy Shaw, basically?
Yes. Yeah, and teams that are coordinated through VCHIP are...
Julie Krulowitz is working on this.
So that's sort of the standard set, but as I said, there's hundreds of measures that are actually behind that, but it gives you a sense of the kinds of things that we could build on. I also wanted to. Do you want to say something more about that?
Well, yeah, I just wanted to mention. I mean, this is sort of a critical component of building to success. Actually, being able to have these measures and then use them in ways so that people in practices can learn and change over time. And it really is a big loop. I mean, you've got a lot of the claims data, you can get some of these measures out of the claims data, the readmissions and things like that. But many of the performance measures are related to what's going into the electronic health records. And so you come back to this whole issue of the interconnectivity of the electronic health record and its capabilities. And I mean, it starts with the provider being able, understanding how to input the data, their clinical information into the right categories in the electronic health record, the transfer of that information to the registry, then to DocSite and back to the practice. Or internally within an organization, being able to produce reports from the information the providers are putting that are useful to the practice for improvement purposes. And we are not, we have a plan, we have good systems in place, but that is not a resolved issue at this point. I mean, it should be noted.
These, just stepping back from the particular ones, all seem to focus on people who are sick with illnesses that are being served in the healthcare system. But a lot of the improving health that we're thinking about has to do with prevention or more community-oriented, and the blueprint does too.
Right.
So in a sense, you could capture in this kind of model the teams as far as avoidable readmission.
Right.
But that would be quite different from improving health of other huge groups of the population. So how would we think about the evaluation components for that?
Well, that's, if you get back to this list from the RAND study, they put health status and functioning on there. I mean, I think you could imagine in a perfect world with lots of resources to survey people and administer standardized instruments, that for everybody enrolled in a Blueprint practice on a regular basis, you do some sort of functional status survey and get a sense of how healthy they are and how well they're functioning regardless of whether they came into the practice.
I don't think Cameron's looking at that specifically. I think she's looking at it at like a population level set of indicators, and we're already down that road. I mean, coronary, all the key indicators of population health, we have them.
Well, you could do it that way, yeah. I mean, you could also say, let's make an association between the overall health of a
Right.
population in an area and what's going on in these Blueprint practices. I was trying to make it a more direct
Direct.
connection
Yeah.
to the specific patients.
Okay.
That'd be a cheaper way to do it.
Well-
I was thinking about the model, of our range of models, the one that starts with a defined population. It would only be a piece to look at the healthcare services of a defined population.
IBM has done a lot of work on this with their employees around, I mean, they're very particular about the food that's served in their cafeterias. They want their employees to do a health status evaluation. They have exercise programs. They have different incentives for smoking cessation, participation in their healthy living programs. And they're actually going to be back here at the end of March to talk about that a little more specifically. But I mean, that's a defined population that they have pretty, sufficient. I mean, they can control what they serve in their meals.
So you're bringing in a sense, workplace wellness as another place.
It's another
to look.
opportunity.
But again, the way they capture the information about it is that every year their employees have to fill out a personal health assessment.
Right.
So there's a data capture that they've
Right.
implemented and invested in.
Yeah. And they've tied that to their healthcare expenditures. So that's what we want to learn about, is how they've actually done that.
Great.
So,
These.
yeah, I just wanted to remind you all of the payment reform policy that we voted on a couple weeks ago, which in rereading it, I realized that one of the sentences doesn't really make sense. Never good. But the policy said payment reform pilots shall be developed and implemented to manage costs of the healthcare delivery system, improve health outcomes, and provide a positive healthcare experience for patients, families, and healthcare professionals. What I'll suggest on the next slide is that means we have to measure these things. Measures to evaluate the success of each of these objectives shall be specifically identified. It's the measures to evaluate the success of objectives that I now object to. Shall be specifically identified for each pilot project and presented to the Green Mountain Care Board for approval. So what does this mean? At a minimum, we have to measure costs, health outcomes, patient experience, and provider experience, because we've referenced all of that in that policy, or we have to change our policy. How this would get operationalized, as far as I've thought about it, and I think as far as Richard has thought about it, is that pilot proposals will include an articulation of the performance measurement that will be utilized, and we'll need to look at a couple of things at least. One is, how does it connect with this stuff that's already happening in the blueprint, and where is it being collected from? And the other is it broad enough to encompass the scope of that pilot, whatever it might be, and give us comfort about the adequacy of performance measurement. The measures will likely vary depending on the organizational type and the clinical scope of the pilot. Again, getting back to our favorite little chart there. And the blueprint measures could be adopted for other organizations or units of analysis. Most are very relevant for payment reform models, but limited, as you've noted, Karen. And right now, the way Craig is having those calculated is on a health service area basis and on a full state basis for the purposes of looking at the intervention and control populations, those who are in the blueprint versus those who aren't. And he's having those calculated by OnPoint on a regular basis. Currently with the commercial data, when the Medicaid and Medicare data come in, which is supposed to be it's supposed to be usable by the 1st of next month, he will have those calculations for all payers.
You know what else it means? We've got to figure out a way to translate this inside baseball to the general community. This comes across as very complex stuff, but it's not as complex as it looks. We really need to do that, Karen.
We do, Todd.
B.
Just a question, are you going to be using the hospital budget data to determine the impact of the pilots on the overall financial health of the organization, or are you going to include that in your measuring somehow?
To be determined.
Okay. Just want to make sure that's included.
Find us some volunteers and
Okay.
we'll figure all that out, babe.
So,
yeah, this was your stuff, right?
yeah, so, I mean, we've talked about a lot of measures. Some of these measures, these 4, were actually suggested in the literature or the book that I was reading, and they each sort of touch on a different aspect of the healthcare system. The first is the percent of physicians using an EMR. So you could actually create a measure in a practice and measure fairly simply. I mean, these are more simple measures, I think, that we could get to without a great deal of difficulty. But asking the question, how many physicians are using an EMR in your practice, and are they able to share that information with other providers? So the point that that gets to is sharing of information. This is sort of between the PCPs and specialists, or when a patient goes from a primary care practice to the hospital and then is discharged from the hospital, are they using this information to share with other providers? The percent, and the idea being that better coordination of care improves the quality of care for individuals. The percent of prescriptions that are written by computer, in other words, that's another fairly easy objective to measure. And this is so decision support models can be utilized. What that means is when you write a prescription and the computer knows, or the system knows, that the patient's on 5 other medications and the one that you're writing may contraindicate some of the other prescriptions, you'll get, that's called decision support. You'll get a notification that maybe you should rethink using this medication. So that's intended to reduce medication errors that often lead to hospitalizations or use of emergency. This is an example, but percent of hospitalized patients with heart failure who are triaged to an outpatient heart program prior to discharge. So the point here is that when a patient's in the hospital with a specific condition, before they're discharged from the hospital, there should be a specific plan to triage them to follow-up services that would be required for their condition. And again, this is a way of preventing readmissions to the hospitals, and that somebody would follow up with that patient to make sure they actually kept the appointment or were seen. And then the reliability of the flow of accurate medication lists from hospitals to homes. You know, this is one we've been working on for years in the system, and it has not been easy to achieve. But that's another example of having, you know, when you go to your doctor, that they do have your accurate medication list. Other issues to think about is really, as we think about how we're going to move away from fee-for-service, one, you know, and this is something for the board to think about, is simply saying we're not going to have any more increases in pure fee-for-service rates going forward. That the increases in funding for providers will be used to reward better performance, not to reward based on more volume created. So that's something to consider. The assumption of greater financial risk, and this goes to the chart with the arrow going up. As organizations assume greater financial risk, they should be also provided the opportunity to have greater potential rewards as well. And then to achieve greater margins, and this is, you know, I think from a hospital perspective, hospital CEO perspective, we always think of the margins being created by more revenue. But if these different payment methodologies come in, the way to increase margins is going to be through more effective, efficient, and creative ways of providing services. And that, you know, that means using services that are more cost-effective in the delivery of care, and looking at your own costs within the organization and reorganizing your structure. That's another way of achieving additional margins rather than through more revenue generation.
And then the handout I gave you has 2 different tables in it. The first is just a summary of the performance measures associated with each of those 11 major models. And I found it interesting because they summarize not only the measures that are most often used, but also the types of measures that have been proposed but aren't in wide use yet. And that's where you'll see functional status, for example, comes in there. Patient experience sometimes comes in there. Again, to Karen's point, a lot of this has to do with the process of care. So people who are getting care and how is that clinical process or the outcomes of that, but not so much with prevention, except to the extent that HEDIS prevention measures are built into some of these models. And the second, so that's table 3.3. Table 3.4 talks about some of the challenges associated with measurement around some of these models. Interesting reading for bedtime. And I think that's the end of our... So the idea of all this was to give you a sense of, again, both on the, in terms of the clinical and financial model, how do payment reform and Blueprint fit together? How can the Blueprint be a foundation, at least a partial foundation? And then same on the measurement side, how can the Blueprint current measurement be a starting place for us in terms of thinking about broader measurement for broader reform models? So I hope that was helpful.
I have a comment.
Yeah.
Richard, you knew this was coming. But, and I love the title, Chaos in the Organization of Healthcare, in terms of measures to consider. I have not faced any more chaotic situation in healthcare than dealing with the person who has a life-limiting condition and no one has addressed their goals of care. And that is a measure that will bridge both primary and specialty care.
And what's the measure most commonly used? Just existence of orders?
No, you develop a system where primary palliative care is provided by the primary care physician and specialized palliative care is provided in the hospital setting for the patient who clearly has a life-limiting condition and no one has addressed their goals. The only things they are facing is the medical goals. So you develop that, and we're working on that.
Is that usually measured as the availability of that service?
No, it's measured as specific things that you do in the patient-centered medical home or in the critical care unit. And that is a win-win situation. There's no greater satisfaction that a patient or family has when someone has addressed that, and it reduces costs of suffering and unnecessary care at the end of life. So,
and that is, Alan has been a great advocate for this, and it is a component of the oncology pilot that we're considering in St. Johnsbury with Dartmouth. So, we were just looking at that.
So you knew it was coming.
I did, and we were ready for you, and palliative care was right
you
there.
could have, well, I know, but some other measures.
Okay, so we should add that to our measure list.
Okay.
Other...
I will just make one other comment, being a primary care physician who's kind of a magnet for feedback about the Blueprint. And knowing now that our first NCQA guidelines came out in 2007, and now all our practices are facing a new set, the 2011 guidelines, which means they're being rescored. And hearing both from FQHC and my independent practicing partners and my primary care providers in larger groups, that this is quite an onerous experience, to say the least, and that the financial model, given the fact that these are the providers that are the lowest paid in the system to start, has got to catch up fairly quickly. And Craig and I have talked about that, and Pat Jones, and we're all working on it, but the fact that a new set of guidelines came about at a time when we're trying to promote a really good clinical model without the right kind of financial backing makes me very worried. Almost to the point of that $130 per Vermonter that we're putting into the hospital system. We've got to look at what percentage of that is going into the patient-centered medical home system. Almost to that amount of what I would call integration.
I just would encourage you, public television in Colorado recently produced a documentary on healthcare in America. It's called A Success Story. And it follows practices in Grand Junction, Colorado, in Seattle, Washington, and Dartmouth is actually featured on it as well. And just, it's an hour long, or probably 45 minutes. You can watch it, go to pbs.com. It's called Healthcare in America, a Success Story. It's really, I thought, really very interesting in validation of the work of medical homes, of the coordination of care, and the opportunities that exist within our healthcare system to improve quality of care and reduce cost. And this is of a magnitude of 15, 20, 30% reductions in utilization in some areas and cost savings in the millions of dollars. And it really, I mean, it really was very interesting to watch it. Maybe if I could just take a minute. I mean, one example of this I found interesting was in open heart surgery. One of the hospitals was transfusing blood during the operation. And the blood cost is about $1,000 a pint. I don't know what the charge would be on it, but the cost was $1,000 a pint. And the surgeon couldn't really come up with a valid reason for transfusing blood during this procedure. I mean, they just did it, but there wasn't, in his mind, any documentation of value added for that procedure. And what he found was, in checking with other facilities that do open heart surgery, that the range of transfusion was from 0 to 100%. Every case was transfused, and in some cases, there was no transfusion. And so they developed their own criteria for when they would transfuse a patient. And over a 2 or 3 year period, they saved about $12 to $18 million. Now, if you're in a fee-for-service environment, that's a $12 million loss, you know, and probably a $30 million loss of revenue, of charges for the hospital. If you're in a global budget, it's a savings of $12 million to the hospital that they can add to their bottom line. So it's a very different perspective depending upon the way you're paid and how anxious you might be to implement a change like that.
Your salary's on the global budget, isn't it?
We pay,
Yeah, mine is.
We measure his performance daily.
Yeah.
I
I just sent the link to that to all of you.
Richard,
You
how
sent
would
the
that
link?
work?
It's PBS, yes.
DRG-based or charge-based?
They may have been paid DRG based, so
So it would've
there
been-
would have been a savings, right?
Not revenues.
Right, in that case, it would have been revenue.
So Craig will be coming?
Greg's coming in 2 weeks.
Good point.
Because we have had a discussion about what is the right size of the per member per month to really incent meaningful change. We know that $1.5 to $2.5 is not the right size. So maybe
Medicare's got it right.
well, there are Medicare pilots that are paying $20 per member per month.
Right. That includes the community health teams. So.
Yeah.
That includes
Yeah.
the community health teams.
And our
right?
total
So-
payment for Medicare is 10 something, right?
No.
No, it's
No.
the same.
It's the
It's
same.
a
No,
dollar.
is that Medicare's paying for the community health teams too?
They're paying for the SASH teams.
Oh, okay.
the same.
Well, I think their
So I
total
think-
per person is $10.
Yeah, that
But
may-
there is actually discussion with the legislature this session about raising the Blueprint fee.
Where's the money going to come from?
Richard's salary. He's a true believer. Yeah.
It could come out of Craig's travel budget. Thought.
Good.
Come on now.
All right.
Costa Rica kid.
Yeah, right. Any
They
other
didn't
comments?
invite me to speak.
Any other comments from board members or staff? Any comments from the audience or questions? Yes, well, sorry.
Yeah,
Connie, you want-
just one little observation. What we have to put these people through is our requirement. This is how we.
Our education
this
must
is-
happen in public,
it has to
high
happen in
heat.
public. These are not things that we've talked about, so I mean, this.
If we want to have this kind of
Yeah,
discussion.
you're going through the same
You have to
process.
sit through us with us, yes, and we turn the heat up.
Yeah, why do we turn
We turned it down earlier. so-
Oh, God.
We don't turn it up, it just has a mind of its own.
All right, Walter.
I'd like to ask Richard, in his example, what was the patient's view of the transfusion, et cetera?
Well, I would
having
assume
had
they
them-
were unconscious during the procedure.
Yeah.
But But
Before,
I
after?
mean, it's a good question, because I think that should be something that's clearly explained to them.
Yeah.
You know, why we would do this or why we wouldn't.
And what are the risks?
And what are the risks, what are the
Yeah.
gains from not doing it?
Hepatitis cases.
Because there is a significant risk of transfusion.
There is, and I've actually
Right.
had to face that decision before.
Yeah,
So-
yeah. But that is something that should be absolutely discussed.
So I was wondering if the documentary even covered that, but
I don't know that they
They
did.
did.
They did mention the risk of the transfusion. I don't think they
Okay.
mentioned the discussion with the patient.
Any other questions or comments? Oh, Thomas, yes. I thought Karen made your comment.
Well, I got a little bit more to say here. First, I'd like to congratulate the board for putting their attention on improving the health of the people as a means to reduce medical costs. And I'd like to expand the paradigm slightly from improving the treatment of disease to preventing the birth of disease. And in particular, there's a bill that if it gets out of the healthcare committee by next Friday and then gets passed, I believe put us on the path of actually reducing reducing costs over time as opposed to reducing the rate of increase. And it's called H64. And there's a group of us who are trying to get the input from the population. And there's a petition out now, and it's this little piece of paper here that Walt's going to point at. Oh, I am. Yes.
This is getting good.
Okay.
Where is it? Yeah.
Okay. Basically, if you go
got
to
a prop all set up. Look at
oh,
you,
look at
Thomas.
this. Oh yes, I figured out how to do the titles and subscripts. You do it on paper while taping it, and this can be out tonight or tomorrow morning out on the web.
better zoom this, Tom.
What?
You better zoom this in.
Okay, here's the Zoom right up here.
All right, the point is,
So basically, there's a petition to be signed, and we're trying to get people to give their input to the legislature that if they pass this bill, we can actually reduce healthcare costs by having a separate path for reimbursement, not just for treatment, but also for procedures that actually reduce the cost, that actually make people healthier, and healthier people actually do that.
through birth control.
Well,
It's
that's
rather
what-
controversial this week. You may want to talk to the Republican
Okay,
candidates.
but those of us who are already birthed.
Birth of disease. Yeah.
Wow.
So anyway.
Where did we go?
But wouldn't you rather be healthier as opposed to being sick and having to pay all these medical bills?
Absolutely.
And,
Thank you.
and the research says a small investment in true prevention, primary prevention, which prevents disease from ever arising, is actually cost effective in that you can actually reduce. The estimate is for one treatment over the United States, you can save $10 trillion in 10 years just by reimbursing true prevention.
Okay.
Thank
Thank
you.
you very much. Thank you all. We're having an open house across the way in a little bit. When does it start? 3:30. You're all welcome. And I think that's all our business. We have 2 meetings next week, and we're back at the Pavilion on Tuesday. And thank you all for coming. Nice haircut, Ralph.